Morning everyone. Today I'll be presenting on the unicompartmental knee replacement. These are the topics I'll be presenting with relation to unicompartments. The data will be focused based on the AUA National Joint Registry from 2023. In terms of types of knee replacements, 7% of knee replacements were partial in Australia in 2023. 5% of these were unicompartmental. The peak or popularity of these was in 2013, where 14.5% of knee replacements were unicompartmental. The different types of partial knee replacements include partial resurfacing, unispaces, bicompartmental, patellar and trochlear replacement, and unicompartmental knee replacements. Although on the joint registry they only analyse modern prostheses, defined as prostheses available and used in 2022. So partial resurfacing, unispaces and bicompartmental were taken off the analysis due to early revision and high failure rates. Unispaces, seen in the image on the left, has been taken off the market in 2005. So in terms of the advantages to unicompartmental replacements, in terms of patient factors, there's reported faster recovery and rehab, shorter hospital stays, less pain, surgical factors, smaller incisions, lower cost, lower complications such as bleeding and infection, preservation of normal knee kinematics as the ACL and PCL is retained, and patients have increased range of motion. The disadvantages to a unicompartmental knee replacement is that it's more technically challenging with increased revision rates and supposedly has poorer future total knee replacement results. So historically it was thought that patients who had a conversion of unicompartmental to total knee replacement had much poorer survivalship due to bone loss requiring grafts and augments, and is thought to have a 3.5 times revision rate compared to primary total knee replacements. However, there's been multiple large retrospective cohort studies more recently which suggest this conversion of unicompartmental to total knee had the same rate as primary total knee replacements. So the poorer total knee results are still contentious. The indications and contraindications for a unicompartmental replacement is controversial and varies. But with the current criteria, only about 6% of patients meet this criteria. There's a lot of studies to see if the criteria can be expanded, particularly to younger patients. So indications are for unicompartmental disease. Patients must pass the finger point test and point to only a single compartment of knee pain. Lower activity levels, age of greater than 60 and thinner with a weight of less than 82 kilos, to minimise failure and revision risk. Contraindications, a long list including inflammatory arthritis, ACL deficiencies, deformities with fixed varus greater than 10 degrees, fixed valgus greater than 5 degrees, fixed flexion greater than 5 degrees, and a range of motion arc of less than 90 degrees, previous meniscectomy in the contralateral compartment, tricompartmental osteoarthritis in patients who are at high risk of early failure and revision, such as the younger patients, high activity, heavy labourers, and symptomatic patellofemoral joint osteoarthritis. Some surgeons may choose to operate on patients with asymptomatic patellofemoral joint osteoarthritis. In terms of this indication in Australia, majority of them are males, about 60%, and age between mid-50s to mid-70s. In terms of implant design, the fixed bearing was the original design, and then the mobile bearing was introduced later with the thought to have decreased wear pattern and increased survivorship, although the disadvantages to the mobile bearing is that it's more technically challenging and the bearings can dislocate. It's interesting that despite the design of the mobile bearing, our joint registry doesn't reflect the increased survivorship, with the fixed bearings doing significantly better both statistically and than the mobile. So at 20 years, the hazards ratio of needing a revision for the mobile bearing was 1.5 compared to the fixed bearing. In terms of popularity, the fixed bearing has significantly increased after 2015, which was the year the Mako robot was introduced. So about 70% of the unicompartments are done with a fixed bearing in Australia. The Mako implant for the fixed bearing is seen on the left here, and that's the Striker Restorers. And on the right here, we've got an example of a Poplar mobile bearing, the Zimmer Oxford. Common complications and modifiable surgical risk factors: aseptic loosening associated with malalignment of components and undercorrection of the deformity, progression of disease or osteoarthritis associated with overcorrection of the deformity, which leads to overloading of the contralateral compartment, stress fractures and tibial subsidence associated with over-resection of the tibia and the tibial component positioning, so over-impacting the tibial component or undersizing it can lead to subsidence, and factors to do with the guide pin, so penetrating the posterior cortex and the medial cortex and needing to re-drill is associated with that. As we discussed at our X-ray meeting last week, the most common causes of revision were progression of disease, loosening and pain. Early revision was most commonly done due to aseptic loosening, and late revisions were more commonly due to progression of disease, making up about 36% of revisions. Interestingly, robotic-assisted unicompartmental knee replacements had a much lower, robotic unicompartmentals is getting much more popular, and they also have a lower revision rate on the registry too. So currently about 30% of the unicompartmentals are done using the Mako robot. And looking at the survivorship, the revision rate is both higher and statistically significant when the robot wasn't used for a unicompartmental, with the hazards ratio of about 1.3. Although interesting to note that the revision rates were different, the cause for revision was different on the robotic versus non-robotic arm early, but then late the revision causes were the same. So with the robotic assisted unicompartmentals, the most common early cause of revision was infection, which I presume may be associated with the additional equipment requirements. But late revision was still the same: loosening, progression of disease, and aseptic and pain. Comparing the revision rates of a unicompartment with a total knee replacement, revision rates are much significantly higher in the unicompartmental than total knee replacements. At 1 year, the revision rate is about double. At 10 years, the revision rate is about 2.5. And at 20 years, the revision rate is almost quadruple compared to a total knee replacement. Although there's a lot of confounding factors associated with this. So the mean age for unicompartmental patients are much younger at 75, and mean age of total knee replacements are at 68. The survivorship is much lower of a total knee replacement in terms of the patients. So at 20 years, only about 40% on the joint registry are still alive, whereas with a unicomp, about 60 patients are still alive. So I think this can significantly confound into the revision rates as well. And males were most likely to get a unicompartmental knee replacement, making 55% of the cohort, whereas females were more likely to get a total knee replacement, making up 56% of the cohort. So the discussion's interesting that unicompartments have a much higher revision rate, and it's a known factor, but then I think it's still a worthwhile and considerable option, especially for considering that patients get out of hospital earlier, early rehab and earlier function and recovery. And although the younger patients have a much higher revision rate, they often are getting done more and more for the younger patients just to get them back to things earlier. So it's interesting to, as an option, although keeping in mind that with total knee replacements the revision rate is still significantly lower. These are my resources here.